Good morning, everyone. Uh, this is Jose Shapusnik, and I have the distinct honor today to introduce Dr. Velma McBride Murry, who is a Vanderbilt University Distinguished Professor and holds an endowed chair. She currently serves as the co-director for the Health Equity Research Program at Vanderbilt University's Medical Center. Uh, Dr. Murry is past president of the Society for Research on Adolescence, and she's currently the president of the International Consortium of Developmental Science Societies. She's a member of the National Academy of Medicine, and she's also currently a member of the National Advisory Council for the National Institute of Mental Health. Her research examines the significance of context, family, and culture, for example, to everyday life experiences of African American families and youth, focuses on process through which racism and other social structural stressors cascade through families to influence parenting and family functioning and cascading to developmental outcomes and adjustment among youth. I could go on and on introducing Dr. Murry, but we want to hear from her. So please join me in welcoming Dr. Murry.
Thank you so much, Dr. Sopachnik. It's been it's really a delight to be here, and I was just saying to you that we've been trying to do this for quite a while. So I'm glad that we've finally been able to find a date for me to share my work with this esteemed group, and I have allowed time for the group to interact with some of the work that I'm presenting here, and would love to hear more about your thoughts about what I have said and have shared with you today. And I'm just getting my slides together so that I can begin to present. So I will. Okay. And share.
We can see.
Great, excellent. Okay. So can you see just the slide itself or both slide and presenter's view?
It's the presenter's view right now.
Okay, then I'll just do just the regular slide. Okay, how's that?
Perfect.
Okay. So when Jose and I were talking about what to focus on today, I thought about sharing with you ways in which, well, one, addressing a critical issue confronting African American families, and then the way in which we have translated information from a longitudinal study that started in 1991 when I was at the University of Georgia, and how that program informed the design of preventive interventions. And I want to leave the group with a thought about how we can begin to increase access to evidence-based program to address many of the critical issues that are confronting African American communities. And I'll start by saying that I have nothing to disclose and no critical benefit in terms of what I'm presenting, except the fact that I get the pleasure of being able to do this kind of research, and also acknowledging the funding support that I have received in order to be able to do this work, as well as acknowledging the wonderful contributions that our families have made, our community liaisons, and if we have time, I can talk with you a bit more about the role of our community liaisons in helping us sustain these samples over the course of many, many years, the dedicated schools that are willing to help us, and of course, the research staff. And these are the things that I am hoping that you will be able to get from this presentation today, and that is an acknowledgement of the fact that there are historical and current cultural factors that impact what happens inside families. And I think we'll get a chance to see a bit more about how those structural historical factors continue to impact families as we look at the shifts that may be happening in our country as a consequence of the current administrative shifts. Going to also describe how evidence-based programs that have shown efficacy and effectiveness in strengthening families may be a way to disseminate effective preventive intervention programs through not only primary healthcare settings and primary care settings or healthcare systems, but it also may be a way to embed these in various community organizations such as religious organizations and youth service delivery spaces in order for us to begin to address disparities that are confronting these families. We oftentimes try to understand what is it about children's circumstances that influence the need for us to begin to think about ways to address what is happening to children to improve their life outcomes. For many of us, we look at adverse childhood experiences as a tool or a framework to help us understand how critical issues that affect children or adversities have implications for developmental and life course trajectories and adjustment. It is with reason that we should think about adverse childhood experiences because those experiences spill over into impacting the health and well-being of individuals as they begin to transition, not only from childhood, but throughout the adult lifespan. What we know is that 1 in 6 adults experience 4 or more types of adverse childhood experiences, and that 5 of 10 of them, and at least 5 of the top leading causes of deaths are associated with ACEs, and 44% of them actually could be reduced or prevented if we would begin to understand ways to address these adverse experiences. This particular graph shows you how adverse childhood experiences are proportioned across racial and ethnic groups. And you can see from this chart, if you look at those that have had 0 numbers of adverse experiences, Asian groups report higher percentages of 0, followed by whites and then Hispanic. But those that are of Black or African American origin are least likely to say that they've had no experiences, but more likely to say 2 or more. Now, one of the things to be thoughtful about as we look at these data as well is the extent to which populations have been included or excluded in a lot of our data collection techniques. So we should be mindful of that, and the fact that we know nothing when we collapse a lot of groups into this other category. So I say all this to say that some of these data may not actually be truly reflections of what's happening in the lived experiences of these youth, but what we do know is that Black youth are more likely to experience adverse childhood experiences. And why is this important? It's important because it helps us understand variability not only in the psychological outcomes of these individuals, but as Arlene Geronimus would tell us, that these things have a way of creating an allostatic load that began to manifest itself in not only looking at the psychological impact of these experiences, but that it also has been linked to chronic disease, disabilities, a lot of social problems, and for many of these young people, early deaths. And it occurs by the way it enters into our social and emotional responses, such that when we go through these experiences as a child, we begin to experience impairment in these major domains of development, social, emotional, and cognitive. And that when these impairments occur in these major domains of development, it then begins to spill over in the way that we begin to respond in our behavior. That has been also linked to high-risk behaviors, such as there is a body of literature that would say that children that have experienced adverse childhood adversities are more likely to engage in early risk behaviors that place them at risk for HIV transmission, which is what led me to the body of research that I have studied for many years. But it not only impacts the behavior, but it also impacts brain functionality, the decision making, the amygdala of these young people's brain that influences how they make decisions about what they're going to do when they're in risk opportunity situations. And it also been linked to inflammation. And all of these then spill over to predict then these health risk outcomes. And I'll talk now about how we see adverse childhood experiences showing up in the life of Black people or Black African American people. Over the past decade, there's been great concern about the suicide rate increase among Black children ages 10 to 11, with an increase of 233% over the past decade compared to non-Hispanic whites. Black females are at risk in that 60% of those in grades 9 through 12 were more likely to attempt suicide in 2019 as compared to non-Hispanic white females of the same age. And those patterns have only increased, skyrocketing to 78% increase 2000 to 2020. We're seeing even higher patterns as we begin to look at the implications of COVID-19 on these young children, where we're seeing increased risk for suicide among children ages 5 to 12, approximately 2 times more likely to die by suicide than their white counterparts. It's the second leading cause of deaths among African Americans, increased significantly 33% for those ages 10 to 24, with almost 23% of those aged 24 to 44. So it's spillovering even into individuals as they reach young adult and middle adult age. It is a suicide death rates for Black and African American men is 4 times greater than that of Black or African American women. So when we look at reasons given for why these patterns may be occurring or any other pattern of risk that we see, particularly among individuals of color, it's always attributed to the individual. So you look inside that person's lifestyle to try and explain why it is that these things that we're seeing is happening to them, and that their lifestyle is leading to these psychological responses. And that it's that lifestyle then that's leading to the physiological responses, hypervigilance, behavior, elevates blood pressure, creates heart rate problems that then lead to obesity, that then leads to diabetes. But all of it is supposed to be related to this internal person being able to control what's happening to them. And if they could control that, then you wouldn't have this bidirectional effect of getting really upset that cause your allostatic load or your hypervigilance to lead to problems of anxiety, depression that then leads to all of these things. But the explanations are for the person themselves. But adverse experiences primarily focus on the setting where children live and reside, without giving a lot of attention to ways in which the ecological system actually creates circumstances that cause these adverse experiences to happen. Again, looking at children who are in neglectful homes often attribute that to something wrong with the parent, rather than looking at these larger systems, as Brennan would tell us, that spill into the life of families to influence what happens. So my work focuses primarily on looking at structural or systemic racism and its consequences for families, because we see these systemic structures or racist structures happening in the kind of systems that families have to interact with in order to raise children and live and work themselves. So we can see the manifestation of adverse experiences happening as a consequence of ways in which these families are interacting with these larger systems that have been designated as the social determinants of health. We've oftentimes pay very little attention to those systems, but we go internally to look at what's happening, moving very few times to institutional spaces, except some of us look at schools, but most of us look at those interpersonal and internalization or the filtering inside of those systems and try to remedy those as a way of correcting these structural problems. But we do know that racism breeds all of these problems, all the way from mental, behavioral, and physical health problems. So Vivian Mays would tell us that a major part of this puzzle that we have linked the individual lifestyle to these outcomes happens by looking at the way that structural and systemic oppression and injustice influence the lifestyle, and that we also look at the way in which these things influence the way one looks at their own life situation, such that when you interact with systems where you're having constant exposure to racial discrimination, how does it really begin to help you make meaning of that to the point that you begin to think about what's possible for you? And that those processes then are part of the cognitive appraisal response. If you think about the early model that I showed you of looking at how ACEs gets under the brain or under the skin, and that is this significant process of these interactions between the structural systemic racism that it then leads to the outcomes that we see. But there's no direct link, while we assume that it is, between lifestyle and these outcomes. The process of the mechanisms by which it happens is much more complex than that. And so it's manifested as racism getting under the skin, in other words, and it has been linked to social determinants of health. So all of these responses, this anger, can be linked to psychopathological and mental health problems, but it's coming from this system level structure. And when we begin then to look at trying to understand this phenomenon, interestingly, most of the attention is given to what's under the iceberg. And it's important to think about the fact that we're diving under the iceberg to try and explain what's happening to these individuals, when what is so obvious to us is what's above the iceberg. It's those circumstances, those community level vulnerabilities that actually are created as a consequence of these social structures that increase exposure to these maladaptive processes that then begin to influence what happens in the everyday life experiences. So recently, I guess over the past 6 or 7 years, I've been talking about how do we get rid of this environmental hazardous pollutants that's really causing these exposures to filter down into the life of these families at the individual level. And we could talk about it a bit more if time permits. So the reason why it's important to look at structural and systemic racism or oppression over time is because of the economic, psychosocial, physiological stressors, in addition to the amplification of race-related experiences, has a lot to do with how one goes about coping with their life. This cumulative stress then elicits a cascade of biological responses that may be function in the short term, in that people may be able to navigate and manage it in the short term, but in the long term, it wears and tears on the body, and the psychological responsivity begins to show up itself in a way that our organs begin to respond to the stresses that we're going through, and that it leads to early aging, which my colleague Jean Brody has shown in a lot of the data that we have on looking at the long-term effect of exposure to racism on African-American youth. Arlene Geronimus refers to this as the weathering hypotheses, and notes that this weathering hypothesis score is much higher among Blacks than it is among white Americans. And that is what's just documenting the early onset of diabetes, cardiovascular problems among African Americans, and that it exists across all socioeconomic levels. One of the true patterns of demonstrating that is if we look at maternal child health and deaths, it is the same for Black women, regardless of SES. So SES in many instances does not protect us against racism. And I wanted to demonstrate this. This is a recent paper that I just published showing how we have to think about these major chronic events happening not only to the individual, but it happens historically in families, and that this historical trauma follows individuals throughout the life course, not only of themselves, but the life course of their families. And so when we're trying to understand what's happening in the life of young people, children, adolescents, and young adults, they bring with them this historical contextual stressors that their ancestors have experienced. As our indigenous populations would tell us about the historical trauma, it doesn't leave the family. It becomes part of the epigenetic manifestation of stress in the life of these families. And we should then begin to think about this in a transgenerational perspective rather than a current generational contemporary perspective. I also developed this model to show how these historical trauma experiences actually continue to remain in families, even though they happened several hundred years ago, that it still happens because these are the kinds of laws and practices and way of the fabric of our society that leads to current incidences of structural contextual stressors. And we see it really in the way that we begin to have these categories that we call marginalized or minoritized populations. It's not a consequence of just who you are phenotypically or an origin of your own racial ethnic heritage. It's a consequence of the fabric of our society. This society then produces what I call these mundane extreme environmental stressors, which oftentimes, which as you look at them, they actually map onto the social determinants of health. That then results in these inhibiting, these vulnerability processes in families. And it also can lead to variability in the adaptation of these developmental patterns in families. And then I talk about the fact that most families really do well despite living in this very structural oppressive society, suggests that they're drawing on their ancestors' strengths that they have transmitted over generations to explain to them how you make a way out of no way despite living in a very oppressive society. And it's drawing on these ordinary magic, as Ann Maxton would refer to them, that really leads to these family promotive strategies despite having to deal with these mundane stress. But there's a lot of energy and taxation happens as these families are using these strengths in order to be healthy, to then develop positive and healthy children. So the other part of this puzzle is that there's social drivers that create barriers for behavioral health seeking behaviors. And just as our society creates these social positions, it also influences who can and who cannot have access to various kinds of services in order to be healthy. One of the things that we know is that, and it was very obvious during COVID-19, we need many more people specialized to understand the lives of African American families, as well as other racial and minoritized populations. And that there is also a tendency, particularly among African American, as Dr. David Satcher would tell us, is to minimize mental and behavioral health problems and to really think about it as something that you shouldn't give into, because when you give into it, particularly for African American women, it's a sense of feeling that it's a sign of weakness. And so you don't legitimate the fact that you're having these depressive or anxiety problems because you just want to get through the day. You don't have time, as this woman wrote many years ago. I have so much to do as a single Black mom. I don't have time to take time to realize that I'm blue. So there's a social stigma as well regarding mental health problems in the African American community, because there's this thought that if you talk about what's going on inside your family, it's putting your dirty laundry in the street, and you don't want other people to know really what's going on, because you also don't know how it's going to be used against you later. So there's a reluctance then to seek primary care, and oftentimes relying on ministers and prayer and confining in relatives, and off as a way of really getting through the psychological problems that they may be confronted with. As a consequence, oftentimes they go untreated because of one, suspicious of the professional healthcare system, lack of access to it, and when they do go in for care, lack of receiving quality care, and may make them feel that they shouldn't be there, and so therefore they don't go back. So there's a concern also about the ethics of clinical science, a real suspicion about research science and clinical experimentation with reasons. While many of these families can't tell you the detailed story about the Tuskegee study, they know that something bad happened to Black people as a consequence of research. So you're confronting that when you're going into these communities for them to begin to believe that you're going to be upfront and transparent in the work that you're doing with them so that they don't believe that they're going to be experimented on without their consent, even though these situations are still happening as of today. So the suspicion about how the data is going to be used and who will benefit from it, the researchers or the African American community, also really creates problems getting them into service. And then they want to know, why are we being targeted for this particular service? When you come into their community, say, we're going to offer a positive youth development program, and we would like to enroll your children in this program. So my colleagues and I decided we wanted to get a much more in-depth understanding of Black families' perception of mental health-seeking behaviors. And we asked a set of questions, and I'll just share a little bit of that with you today, that then led to us wanting to know the importance of including families as a process of elevating children's positive outcomes. We asked the question of these families, what are your preferred sources of mental health care for your child's behavior or emotional problems? We targeted families in our single mom study whose child had been clinically diagnosed for each of the behavioral health issues that you see displayed on the screen here. And you can see that 12 of these, so these were 22 families that we got in-depth qualitative data on out of a sample of 200 and something families. These were families whose child were clinically diagnosed as having behavioral problems. And you can see where they lie, behavioral problems and ADHD, with depression also coming up pretty close in terms of percentages. Then we asked them, okay, now that your child has been diagnosed, what is your preferred sources of mental health for seeking care for your child? You can see where the percentages lie. Family was the first choice, followed by school counselors. Pastors were next, teachers, the primary care doctor, friends, and look at where the professionals are. Way on the bottom of the list, with psychologists being the last preferred choice for help-seeking behaviors. Then we asked them, when your child did receive care, how were you referred? The school referred them most often, and when they informed the doctor, the primary care physician, that the school indicated that their child needed help, oftentimes the primary care physician is what truncated or stopped them from going, because they would minimize the need for their child to seek help, mental health services. And as a side note, I want to tell you that most of these families' children received mental health care as a consequence of becoming part of the juvenile justice system. So, missed opportunities to really impact the life of these children by serving as a referral when the problems were noticed by the schools. What we realize from the parents' preferred choice is that families may be a mechanism of behavioral health change. They're the most fundamental and proximal social system connected to the child. The question then becomes, how do you increase access of successful evidence-based behavioral health programs to families through family-based preventive interventions? And so what we decided to do was utilize studies based on our longitudinal research data on these African American families, and then begin to develop programs that are culturally appropriate for implementing in these areas, focusing on those proximal mechanisms that are really linked to impacting minoritized population youth health. And so we translated data from our longitudinal developmental studies called the Family and Community Health Studies that we've written lots of articles about. There were mechanisms that kept emerging as pivotal mediators that reduced the likelihood that stressors were going to lead to negative outcomes. We took those positive mechanisms and moved them into two preventive intervention programs, one called the Strong African American Families Program, and the other one is an e-health delivery platform called the Pathways for African American Success. And what you see in these two first boxes as our intervention targets are the things that we found out from our families that mattered in terms of the way in which they were able to reduce these negative outcomes in their children. And so we focus on these parenting strategies that led to these youth protective processes that then reduced these outcomes that were occurring during adolescence, with the intent of hoping that these programs would have long-lasting effect as these young people move from middle childhood to early adolescence. This first model shows you that indeed this is exactly what the program was able to do, that our parenting processes led to increased parenting, that we were, in other words, able to enhance those parenting processes through the SAFE program. By enhancing those parenting processes, we were able to then directly enhance those youth protective processes. These youth protective processes help kids with the decision-making processes that they would recognize risk opportunities and avoid those risk opportunities to engage in sex, smoke, use drugs. Those protective processes really served as a mechanism of protection that then reduced the likelihood of engaging in risky behaviors, not only for the particular period of time in adolescence, but had long-standing protection as they transition into young adulthood. We also realized that because of what we were targeting in these parent and youth protective processes, that we were probably doing more than just reducing early onset of sexual activity, drug use, sexual risk practices, and elevation of drug use and alcohol use, but we were probably doing something else. We've begun to now look at what was it, other things that we were protecting that weren't necessarily targeted. And one of them was recognizing that schools or places where kids experience adversity, we wanted to look at whether or not parents were doing things particularly that were preparing their children for the biases that they were going to be experiencing in schools that oftentimes lead to academic disparities. And so this is a paper that we did last year. And in this paper, what we show is that from middle childhood to middle adolescence, the SAFE program was effective in enhancing these parenting processes that we call academic racial socialization parenting practices that led to increased youth self-pride, or these internal youth protective processes that then led to increased academic competence, and that this was protective even in the consequence of experiencing depression in school. This academic competence emerging from this parent's academic socialization reduced the likelihood of academic failure and the likelihood of dropping out of school, and that this pattern was greater for males than for females. And so you can see the SAFE program, while it was designed to reduce early HIV risk vulnerability, was also enhancing academic or addressing academic disparities. So overall, the SAFE program targeted those malleable things that we found to be protective in the family context that would have immediate facilitative processes over their kids' willingness to avoid risk opportunities. And this avoidance resulted in long-term positive consequences for children, kids over time, reducing HIV prevention, HIV engagement related behavior with sustainabilities 6+ years post exposure to the program when they were in middle childhood. So we learned a lot from the SAFE program, but one of the things that we learned is that it takes a lot to encourage families to attend a 7-week session that requires them to come out of their homes in order to be able to be exposed to this program. This led to the more recent generation of our preventive intervention program called the Pathways for African American Success. It's a 3-arm randomized trial. The design was 3 active conditions, with 2 of them being engaging with our research staff, and the third one was a literature control where information was mailed to the family's home. This is the design of the program, and I'll just now show a few of the findings so that we can have some time for engagement. So the first thing we wanted to know was how is the EPAT, the PAAS eHealth program versus a small group program leading to post-test outcomes. And what you see is that the eHealth was directly linked to increased conversations from parents about challenging topics. And this program was also linked to the reduced likelihood of kids engaging in risky behaviors. Being in small groups and receiving this program content led to increased supportive parenting for the child, open communication, frequent general conversations, and it also led to increased deviant peer affiliation intentions. We can talk about that if time permits. But the key finding is we were moving the things that we wanted to move, except we did not expect the program to only be much more positively impacting talking about racism, sex, and rules about risk compared to just general parenting. This is a project that was recently published by my colleague, Katie Burkle, where we wanted to find out whether or not the PAAS program was also protective against kids experiencing general racism, as well as parents being exposed to discrimination, because discrimination has been associated with increased paternal depression as well as youth depression. Our question was, can we use PAAS as a way of enhancing those processes in families to reduce the likelihood of the internalization of these experiences that may lead to depression? And what you can see here, we have this concept that we call racial equity informed parenting, and that racial equity informed parenting was increased by the SAFE program, or the PAAS program, which then resulted in increased youth pride, which led to decreased depression. And even in the midst of exposure to discrimination, again, this was a major protective process for these children from middle childhood to middle childhood to middle adolescence. So some takeaway messages from the eHealth Produce program is that it's important for us to think about how do we market products such as the PAAS eHealth to increase competitiveness and sustainability in settings where people can be exposed to them. We thought about primary care settings as a place where families can be referred to evidence-based program because they're trusted partners for parents oftentimes. There's a growing need and interest in embedding these programs. In fact, National Academy of Medicine has started this work group of thinking about how do we get this done. And in fact, my colleague Willie Prada has begun to test this at the University of Miami. But many pediatricians are concerned with parenting but they don't have the time that they can devote toward providing this kind of information to families in the short period of time that they have to be with the caregiver and the child. So technology may be a way to easily meet the needs of these patients. The families in PAAS, they were culturally tailored such that they look like the populations that we were offering the program to. So you can increase the sense of deep dive cultural adaptation such that when families see the individuals in these technology platforms, they may be much more relatable because they look like them. It offers a promising foundation for us to begin to really scale this up into larger settings, including schools as well as faith-based organizations. So I end this by saying then there's a call to action then for us to begin to center equity. Equity, offering these programs in settings that have easy access, where families have easy access to them, is a way of elevating equity. And that we should also give greater consideration to looking at the intersectionality of racism along with other pandemics. Because if you look at the fact that these children are also growing up as a consequence of COVID, as a consequence of climate change, as a consequence of our social, economic, political unrest. All of these things are happening, and I call them multiple pandemics at the same time. That's really going to have a major impact on the developmental trajectories of these children. And that it doesn't only happen once they're born, that it begins to happen prenatally because of what it's doing to the parent as they are pregnant with these infants, and that it lasts throughout the lifetime. Universal screening is also important. We need to screen for not only what's happening in the current family situation of these children, but screen for the toxicity of this environment as they're creating stress on these children. We also need to have a comprehensive examination of how ACEs gets under the skin. What is protective? How does it work? For how long does it create this toxicity? And when does it reach a level of weathering? And the recognition that there are underlying mechanisms that create adversity that impacts all of us. When you're swimming in toxic water, no one gets out unscathed. And we have to recognize that it's not only these racial ethnic populations, but white people are also being impacted by what is happening when we accept these structural oppressive practices and policies in our society. We need to develop clinical approaches that are informed by models that infuse these systems and these oppressive structures in order for us to then begin to create system level interventions, structural level interventions in order to adequately address equity and inequities and disparities. And in the process of doing that, we should examine our own background and our biases as researchers, clinicians, practitioners, and be cognizant of what and who is used as the reference group as we're looking at the extent to which we feel that families have reached a level of optimal functional development. And I want us as scholars to realize that we have the institutional power. We're in the position to lay the foundation and be the forerunner of centering health equity and research practices to address behavioral health. What actions are we willing to take is a paper that I recently wrote in the Journal of Prevention. And I thank you for your time.